Hello class, this is a continuation of our acid-base lecture. In this part, although a short PowerPoint, I really am going to try my best to connect acid-base balance along with internal and external potassium balance, as well as how shifts of potassium can cause shifting of hydrogen ions, and that means affecting a patient's pH. Similarly, pH can affect potassium shifting as well. It is going to be a very dense lecture. Some of it will be redundant compared to the original acid-base lecture you probably just watched. In fact, let me just start with that right now. So, in the acid-base lecture, when I started talking about renal compensation, one example of renal compensation for either metabolic or respiratory disorders was this idea of compensation happening in the PCT, proximal convoluted tubule, or late distal convoluted tubule. And in the lecture, I was talking about the idea of reabsorbing bicarbonate. And what you should also know is if we're reabsorbing bicarbonate, somehow we have to secrete a hydrogen ion. At least that's what I'm talking about right now, secretion of hydrogen as a titratable acid. So this is, again, there are two main ways that we secrete hydrogen: as a titratable acid or a fixed acid. And in my first lecture, I talked about this titratable acid, though I did not use those words. So here we are in the proximal convoluted tubule, and I want you to know that the proximal convoluted tubule, when it comes to reabsorbing the filtered bicarbonate, so here is our filtered bicarbonate shown here. It can reabsorb none, it can reabsorb some, it can reabsorb all of the filtered bicarbonate. When would it be appropriate for the proximal convoluted tubule to not reabsorb filtered bicarbonate? When a patient has alkalosis, if they are already having a higher pH, higher than normal, outside of a normal range, then reabsorbing more base would be contraindicated. When would the PCT reabsorb some or all of the filtered bicarbonate? When a patient is in acidosis. If they're in mild acidosis, then only some of the filtered bicarbonate might be reabsorbed. If they are in severe acidosis, then all of the bicarbonate will be reabsorbed. So down here, I want you to see this enzyme, carbonic anhydrase. Carbonic anhydrase facilitates the reaction of carbon dioxide being hydrated. So we have CO2 combined with water to form carbonic acid, which is H2CO3. And that dissociates into hydrogen and bicarbonate. For orientation, I want you to see that on this side is the lumen, so this is where the filtrate is coming through. And over on this side, we would have the peritubular capillary beds. Okay, so here's the blood side, and I just drew a blood vessel for orientation. Now, when this reaction occurs, when we have CO2 and water forming carbonic acid and it dissociates into hydrogen and bicarb, notice that the hydrogen is secreted through a hydrogen-sodium exchanger. And the hydrogen, in turn, will combine with the filtered bicarbonate to reform carbonic acid, which then dissociates into CO2 and water. Both those things could stay in the lumen and end up in the toilet, or they can be taken back into the cell to have this reaction occur again, but that's not necessary. I want you to remember that CO2 and water are byproducts of cellular metabolism, and we forget that these epithelial cells of the proximal convoluted tubule, they are metabolically active. They are going through cellular respiration. So the CO2 and water are constantly available inside this cell. Now, a very important point is that in our body, our enzymes have very specific characteristics. And those characteristics are substrate specificity. Enzymes, I'll just use a different example right now. Lipase. Lipase is an enzyme that hydrolyzes lipids. It cannot hydrolyze proteins. It's not a protease. So that's what I mean by substrate specificity. Number two, they are temperature sensitive. So if the temperature of your body gets too hot, enzymes can denature. Most enzymes are proteins, so they can denature. If your body temperature gets too cold, the enzymatic activity is also suppressed. So there's a perfect window of temperature range where an enzyme will have its optimal activity. And the last thing you should know is enzymes are also very sensitive to pH. And again, they have a sweet spot for their pH range. Carbonic anhydrase, the enzyme that facilitates this reaction in the proximal convoluted tubule, is no different. The carbonic anhydrase activity is increased when a patient is in acidosis. And that's perfect, because then you would be secreting more hydrogen, and when you are having the carbonic acid dissociate into hydrogen and bicarb, when you secrete that hydrogen, notice what happens to the bicarb. It comes back into the blood. Now the bicarb that was filtered has been chemically changed into carbonic acid and then CO2 and water. It is no longer bicarb. But notice that the bicarb we made in the cell is now put into the blood. So we lost a bicarb here in the lumen side, but we recovered, I'm going to say recovered, the bicarb here in the blood side. No net gain nor loss of bicarbonate in this scenario. And that's good, because if a patient is in acidosis, we don't want them to lose their bicarbonate into the toilet. That is a precious resource. We should recover what is filtered. So that's what the proximal convoluted tubule will do. It will recover bicarbonate when the patient is in acidosis. So these two options of recovering the bicarb will occur when a patient's in acidosis. Now, in alkalosis, when a patient's pH is higher than it should be, that will decrease carbonic anhydrase activity, which is, again, perfect. By decreasing the carbonic anhydrase activity, we do not secrete hydrogen. That means we don't recover the filtered bicarbonate. That means that filtered bicarbonate is on its way to the toilet. We are getting rid of base in that capacity, and that will help the alkalosis. Now, also in the first acid-base lecture, I talked about the late distal convoluted tubule and the alpha intercalated cell. And in that lecture, I again talked about this reaction facilitated by the carbonic anhydrase. Again, on the left side, we have the lumen, which is where the filtrate is. And on the right side, this is where we have our peritubular capillary bed. So I'm drawing in my blood vessel. Notice here that when the hydrogen is secreted, it can be secreted either through a hydrogen ATPase or a hydrogen potassium exchanger. It turns out that the hydrogen-potassium exchanger is actually more important for potassium balance, not so much acid-base. So we'll come back to this and we'll see this later when I talk about potassium balance. The hydrogen ATPase shown here is mostly involved in acid-base balance, which is what we're talking about right now. Another interesting thing to know is that this hydrogen ATPase can be stimulated by aldosterone. And if it's stimulated by aldosterone, as you heard in the previous lecture, we can have over-secretion of hydrogen. And when we make that hydrogen from carbonic acid, we also have bicarbonate. And notice that it is reabsorbed into the blood. And this is new. This is a net gain. If we combine the actions of the PCT with this alpha intercalated cell, we would reclaim our filtered bicarbonate and make more. And that would happen again when pH is low. If pH is low, the patient's in acidosis, and that means carbonic anhydrase activity goes up. And we would see more of this bicarbonate being absorbed. Now, again, this hydrogen ATPase can be overstimulated in diseases like Conn's disease, which is hyperaldosteronism. And that means we'll have an over secretion of hydrogen and an over reabsorption of bicarbonate into the bloodstream, and it will lead to alkalosis in that patient. All right, so now here is a second way where the kidneys can compensate for acidosis, and this is their ability to excrete hydrogen as a fixed acid. Same story that we start with in the beginning is that in order to excrete the acid, we must secrete it. And secretion means we are using a membrane transporter shown here, the sodium hydrogen exchanger, and it is pulling hydrogen from the cell into the lumen, into the filtrate. That actual movement across the cell membrane is called secretion. So when it comes out into the lumen, it's secretion. And notice that sodium is coming into the cell, that is reabsorption. Now, how do we get this hydrogen secreted? This is a different pathway than what I just showed you. This is not using the carbonic anhydrase pathway. Instead, we're using glutaminase, an enzyme. And glutaminase starts with an amino acid as its substrate and then deaminates it. It takes off the ammonia group. And the ammonia group will combine with hydrogen to form ammonium. This ammonium can actually go through the sodium hydrogen exchanger. So it can substitute for hydrogen. This textbook picture, to facilitate students processing how this can work, shows that ammonium can dissociate into ammonia and hydrogen. And the hydrogen can go through the transporter, and ammonia is lipid soluble and can just diffuse out of the cell, recombine with hydrogen to form ammonium. Either way, I don't care how you process it, but out in the filtrate we get ammonium. So this is again in the filtrate. And notice that on this pathway over here, glutamine can also be deaminated into, or chemically changed into glutamate by this deamination. And the glutamate is then used as a metabolite. And in the end, it can be processed as if it's glucose. I guess that's the easiest way for me to tell you that. So if it's metabolized, it's going to lead to CO2 and water. And remember, that can then go through the carbonic anhydrase and form carbonic acid, a story that we've already covered, and it dissociates into hydrogen and bicarbonate. And that hydrogen is where we get this hydrogen from. And the bicarbonate is reabsorbed into the bloodstream. Now this is a net gain. Net gain. So when we use this pathway, the bicarbonate that is reabsorbed is not recovered like we saw in the previous example. It is a net gain of bicarb. Now, on the next slide, I'm going to tell you about glutaminase and how it also is pH sensitive. Again, enzymes in our body have a sweet spot for a pH range. And you're going to see a familiar story where if a patient is in acidosis, the enzymatic activity of glutaminase goes up and we get more bicarbonate, which would be appropriate to have more base to raise the patient's pH back up toward normal. I'll get there in a moment. Right now, I want us to focus on this ammonium. It has two fates. One easy fate is it just stays in the filtrate and will end up in the urine. It will end up in the toilet. So nothing happens to it. From here on to the toilet is one option. But a second option that I will get to in 2 slides is this circuitous route. And we're going to see ammonium get converted to ammonia, be lipid soluble, change body fluid compartments, and then be converted back to ammonium. So that's part of what we mean by the circuitous route. It goes from ammonium to ammonia back to ammonium. It's circular, right? Starting and finishing in the same chemical form. So I'll get there. Just let me now go through how this NH3 ammonia and subsequently NH4 synthesis is affected, what can impact it, I guess. So again, chronic acidosis. If there is reduced pH, this actually increases the activity level of glutaminase. Again, that would be appropriate. It would lead to more bicarbonate and loss of hydrogen through its secretion and subsequent excretion. So that would be appropriate. Hyperkalemia. I'm going to get to that. I'm going to explain in just a few slides how hyperkalemia means an increased potassium level in the blood, in the plasma. That's what emia means, in the blood. And when there is hyperkalemia, then that means we're going to see that when potassium is trapped more inside the cell, and again, I'll explain this, hydrogen must be exchanged for it. So hydrogen leaves the cell. And if hydrogen leaves the cell, then that means the pH inside the cell, intracellularly, goes up. And if it goes up, then that means glutaminase activity goes down. So if the pH goes down and glutaminase activity goes up with a lower pH, it stands to reason that if pH goes up, the activity of glutaminase will go down. And of course, hypokalemia would be reverse that. If we have hypokalemia, less potassium in the blood, this will favor potassium leaving the cell. And this means, and I'm going to explain, I just can't do it all at once. Hydrogen is going to go into the cell. And if hydrogen goes into the cell, this will drop the pH inside the cell. and this will lead to an increase in glutaminase activity. Okay. All right. So now I'm going to continue on, like I said, with the circuitous route for ammonium. Remember, one fate was for the ammonium just to stay in the filtrate and end up in the toilet. Here is the second fate for ammonium. So ammonium, now pay attention, over here is the lumen side. This is where the filtrate is. And here's my blood vessel. And these are the pictures that I supply for you on my notes pages. So here comes our ammonium. This is what we made and secreted in the PCT. So here it is going down the lumen, and some of this ammonium can actually substitute for potassium in the sodium potassium 2 chloride exchanger found on the thick ascending limb. That's what TAL stands for, thick ascending limb. So now we have ammonium in the cell, and then once it gets into the cell, there's a transporter that pushes it into the interstitial space. And this is on the basal side of the cell. So this is the side facing the blood. Okay, so all in here we have ammonium. All in here, ammonium. It just stays there. And now it's in this interstitial space. Okay, and then here's what happens. Again, here's the luminal side. Let's make sure we keep that straight. So ammonium stays in the interstitial fluid, and it is going to be helpful when it's in that interstitial fluid because it will help concentrate the interstitial fluid, and along with urea and sodium chloride that are trapped in the interstitial fluid down at the tip of the loop of Henle, for example, closer towards the medullary region of the kidney, it acts as another particle. It will increase the osmotic pressure, and this will favor more water being reabsorbed by the parts of the nephron that are water permeable. So here's our NH4. This is our ammonium, and it can dissociate into hydrogen and ammonia. And the ammonia, NH3, is lipid soluble. And that means the ammonia can actually worm its way in between cells. Shown here, we're now in like the late distal convoluted tubule and collecting duct. So the ammonia goes through the tight junctions in between the epithelial cells of the collecting duct, and now it's in the lumen. It's with the filtrate now again. And these alpha intercalated cells, remember, they can participate in secretion of hydrogen as a titratable acid. They have that carbonic anhydrase activity. So here we have our carbonic acid dissociating into bicarbonate and hydrogen. And again, the hydrogen can be secreted through the hydrogen ATPase. And that hydrogen then recombines with ammonia to form ammonium, and it's again on its way to the toilet. It's been trapped. It can't diffuse back into the interstitial space because ammonium cannot get through those tight junctions. So it's trapped. I like to think, not to anthropomorphize a molecule, but I like to think that this ammonium, when it was in the thick ascending limb, getting through the sodium potassium 2 chloride co-transporter, it probably was thinking, haha, I'm evading the toilet. I'm going to get back in the body. I'm not going out of the body. I'm going to stay here. And only to have it come right back out of the interstitial space back into the filtrate. That's why, again, this is circuitous. Okay, so again, our alpha intercalated cell. Here's another picture. This is our blood side. Always get the perspective. Here's our ammonia, and it is diffusing, shown here, through the tight junctions. And then here we have our secretion of hydrogen as a titratable acid. And it is now, here's our hydrogen made from the carbonic anhydrase being secreted through the ATPase, hydrogen ATPase. And now it's combining with ammonia to form ammonium, which is a fixed acid, not titratable. Okay. And now I'm going to change gears a little bit. Again, all of these concepts are interconnected. We've got acid base, we've got potassium, which goes along with our electrolyte lecture, and then we have the combination of how we have potassium and hydrogen shifting. With potassium problems, expect acid-base problems in a patient, and I'm going to explain why. So changing kind of perspective here. The first thing I want you to know is that cells throughout your body have a lot of different membrane transporters. Here is a picture that shows just a few of them. I have arrows pointing to some familiar friends of ours. Here is our sodium potassium ATPase. It uses ATP to move 3 sodium out of the cell and 2 potassium in the cell. This helps establish our high sodium concentration outside of the cell and our high potassium concentration inside of the cell. About 90% of the ATP made by cells for during cellular respiration can go toward funding this pump. It is a very important pump. It not only maintains these ion concentration gradients, which is good for excitable cells. It also helps regulate water, because remember, water is made as a byproduct of metabolism. So if you have more particles going out than you do have coming in, water is going to follow sodium out of the cell. Here's another familiar friend, our sodium potassium 2 chloride co-transporter. It is not a pump. It does not use ATP. This, of course, we saw on the thick ascending limb of the nephron. And here is another familiar friend. This is our sodium hydrogen exchanger. We saw that, for example, on the proximal convoluted tubule. When hydrogen was secreted, it moved out, and sodium was reabsorbed in the kidney. Okay, so let's just keep those membrane transporters in our head as we focus on their roles that can affect potassium balance, either directly in the case of the sodium potassium ATPase, or indirectly, as you will see with the sodium hydrogen exchanger. All right, so let me tell you about this potassium issue we have. Potassium is found most abundantly inside the cell. And I want you to know that there are 2 places we need to balance potassium. We need to balance potassium internally and potassium externally. I'm going to explain what internal potassium balance is first. Simply put, internal potassium balance is referring to the shift of potassium to a cell, inside a cell, or out to the blood, or potassium shifting from blood into a cell. So cell to blood or blood to cell. That's internal potassium balance. Again, internal potassium balance is the distribution of potassium across cell membranes from the cell to blood or blood to cell. To re-emphasize, most potassium is present inside the cells of your body. Even small potassium shifts across cell membranes can cause large changes in potassium concentrations in the ECF and the blood. A shift of potassium out of cells produces an increase in the blood potassium concentration called hyperkalemia. A shift of potassium into cells produces a decrease in the blood potassium concentration, called hypokalemia. The table here is telling you factors that can cause potassium to shift out of cells and lead to hyperkalemia, and factors that can cause potassium to shift into cells and cause hypokalemia. I'm going to go through them. Insulin stimulates potassium uptake into cells by increasing the activity of the sodium-potassium ATPase. Physiologically, this effect of insulin is responsible for the uptake of dietary potassium into the cells following a meal, again, from blood into cells. Deficiency of insulin, as occurs in type 1 diabetes mellitus, produces the opposite effect: decreased uptake of potassium into cells and hyperkalemia. When a person with untreated type 1 diabetes mellitus ingests a meal containing potassium, the potassium remains in the ECF because insulin is not available to promote its uptake into cells. Conversely, high levels of insulin can produce hypokalemia. Acid-base abnormalities. So here's our acid-base abnormalities. I'm going to start explaining how shifting of potassium can lead to shifting of hydrogen ions. This is going to take some time, but I will do it. Acid-base abnormalities often are associated with potassium disturbances. One of the mechanisms underlying internal potassium balance involves hydrogen-potassium exchange across cell membranes. That's what this exchanger is showing you here in the picture. This exchange is useful because the ICF, intracellular fluid, has considerable buffering capacity for hydrogen. Remember, proteins are important buffers. In order to take advantage of these protein buffers, hydrogen must enter or leave the cells. To preserve electroneutrality, however, hydrogen cannot enter or leave cells by itself. Either it must be accompanied by an anion, or it must be exchanged for another cation. When hydrogen is exchanged for another cation, that cation is potassium. In alkalosis, the hydrogen concentration in blood is decreased. So if we have alkalosis in the blood, pH is high, it means our hydrogen ion concentration is low. And that means we're going to see hydrogen shifts out. hydrogen is going to favor coming out of the cell down its concentration gradient. If hydrogen leaves the cells, potassium must swap inside as to maintain electroneutrality. If potassium is shifting inside the cells more now, this will produce hypokalemia in the blood. On the other hand, in acidosis, the hydrogen concentration in blood is increased, and this gradient would favor hydrogen going into the cells. So the hydrogen would go in. But then that means potassium must come out. And that would lead to hyperkalemia. So here we would have acidosis. And over here we would have alkalosis. Acid-base disturbances do not always produce a potassium shift across cell membranes. However, and it is important to note the following exceptions. Excuse me. First, respiratory acidosis and respiratory alkalosis typically do not cause a potassium shift, because these conditions are caused by a primary disturbance in CO2. CO2 is lipid soluble. It freely crosses cell membranes and needs no exchange with potassium to preserve electroneutrality. Second, several forms of metabolic acidosis are caused by an excess of an organic acid. For example, lactic acid, keto acids, salicylic acid. Salicylic acid is aspirin. Keto acids would be your beta-hydroxybutyrate or beta-hydroxybutyric acid, acetoacetic acid. Those do not require, will not produce a potassium shift. Moving on, adrenergic agonists and antagonists. So here we are, antagonists and agonists. Catecholamines alter the distribution of potassium across cell membranes by two separate receptors and mechanisms. Activation of beta-2 adrenergic receptors by beta-2 agonists, for example, albuterol, which would be used for patients with asthma, would increase the activity of the sodium-potassium ATPase. And this, of course, causes a shift of potassium into the cells and can produce hypokalemia. On the other hand, activation of alpha adrenergic receptors causes a shift of potassium out of cells and may produce hyperkalemia. The effects of adrenergic antagonists on the blood potassium concentration are also predictable. Beta-2 adrenergic antagonists, like propranolol, would cause a shift of potassium out of cells. And alpha adrenergic antagonists would cause a shift of potassium into the cells. So again, alpha adrenergic antagonists would cause a shift into the cells. How can osmolarity affect the shifting of potassium? Well, hyperosmolarity, increased osmolarity of the ECF, causes a shift of potassium out of the cell. The mechanism involves water flow across cell membranes, which occurs in response to the change in the osmolarity of the ECF. For example, if the ECF is more concentrated, has a higher osmolarity, water will flow from the intracellular fluid out of the cell to the extracellular fluid due to the osmotic gradient. As water leaves the cells, the intracellular potassium concentration increases, which then drives the diffusion of potassium from the ICF to the ECF. And you can reverse this for hypoosmolarity. What about cell lysis? Cell lysis, breakdown of cell membranes, releases a large amount of potassium from the ICF and produces hyperkalemia. Examples of cell lysis would include burns, rhabdomyolysis, which is the breakdown of skeletal muscle, and malignant cells being destroyed during cancer chemotherapy. Exercise causes a shift of potassium out of cells. The depletion of cellular ATP stores opens potassium channels in the muscle cell membranes, and potassium moves out of the cells down its electrochemical gradient. Also, you can think of some of the cells of skeletal muscle possibly rupturing if someone is exercising quite intensely, and it leads to rhabdomyolysis. Now, here's the thing. That picture on the previous slide where I showed you this supposed hydrogen potassium exchanger does not officially exist. An exchanger like that, a hydrogen potassium exchanger, has never been identified in any cell type. But the phenomenon exists. So students say, well then, if the phenomenon exists, but yet there is no actual protein exchanger that's been found, how does this happen? Well, here is one simple mechanism. Here we have our hydrogen sodium exchanger, our good old friend that I introduced or reminded you about 2 slides ago. Sodium diffuses into the cell. Hydrogen is pushed out of the cell. When sodium comes into the cell, the ATPase then kicks it right back out, 3 sodium out for every 2 potassium in. So you can start to see this swapping happening with these 2 exchangers combined. So that's just one mechanism, an easy mechanism, without you going through multiple papers and different cell types. Just think of this kind of hydrogen goes out, potassium comes in. If there is alkalosis, we would have more hydrogen coming out down its concentration gradient. This would favor even more sodium coming in. This would favor even more activity of this ATPase to kick sodium back out, and it would bring even more potassium in, and it would lead to hypokalemia. If we reverse this, if there is trying to get a different color. There we go. If we reverse this and we have acidosis, there would be less hydrogen coming out, less sodium coming in. Then that means the ATPase wouldn't be able to kick out as much sodium. It will not work unless 3 sodium are loaded for every 2 potassium brought in. So if we don't have as much sodium being brought into the cell in the first place, how do we kick it right back out? And that means you wouldn't have as much potassium being shifted into the cell, and acidosis would lead to hyperkalemia. So that is what I was referring to on slide 10, just to go back here. Slide 10, when I was talking to you about, it's an A. When I was talking to you about the acidosis and alkalosis causing shifting of potassium. Again, I want to caution you. not all types of acid-base disorders, as I mentioned, will lead to the shifting of potassium. But the reverse is true. If potassium is shifting, you can expect a secondary hydrogen problem. So if potassium is the initial problem, expect an acid-base problem to follow. If acid-base issue was the initial problem, it is not necessarily true that you will have a patient with a potassium problem. Now I want to shift away from internal potassium balance to external. When we're talking about external potassium balance, we're talking about the fate of potassium as it travels through the nephron. What is its fate? Do we need to get rid of potassium into the filtrate, into the toilet, or do we want to keep it? So when we're talking about external, think toilet or keep. Okay, so the potassium is in the filtrate. If we don't do anything to reclaim it, it's on its way to the toilet. If the potassium is filtered and we do reclaim it, do reabsorb it, then we're keeping it. So that is what we mean by external potassium balance. So it also, all this depends on your diet. A person is in potassium balance when excretion of potassium in their urine equals the intake of potassium in their diet. If excretion of potassium is less than intake, then a person will be in a positive potassium balance and hyperkalemia can occur. If excretion of potassium is greater than intake, then a person is in a negative potassium balance and hypokalemia can occur. Okay, so what is the fate of potassium? Well, in the PCT, we have about 65 to 67% of potassium reabsorbed. Then in the thick ascending limb, we have about 20% or so of potassium that was filtered reabsorbed again. So that means we're roughly around 85 to 87% of our filtered load of potassium reabsorbed. Now, what about that last 15 to 17%? Well, that's where we have the late distal convoluted tubule. And it's the late distal convoluted tubule, two different cell types, and I'll show you two different cell types. So the two different cell types are going to be the principal cells and the alpha intercalated cells. Yeah, so those alpha intercalated cells are not just important for acid-base compensation, but they're also going to be important for external potassium balance. So I'm going to address those two different cells on the very last slide as we go through right here. Just quickly, causes that can increase potassium secretion. You have a high potassium diet, so you need to get rid of it. You have oversecretion of aldosterone. Maybe you have Conn's disease. That would lead to an oversecretion of potassium. Alkalosis. I just went through this. If you have alkalosis and you have shifting of hydrogen out of the cells, then potassium is going to go into the cells. And if we have more potassium going into the cells on the basolateral membrane, then we're going to have the potassium leaking right back out on the apical membrane and into the filtrate. So this is going to lead to more potassium loss on the apical side. Thiazide diuretics. Basically, if we have more thiazide diuretics, there will be more sodium and water arriving near to the principal cells and alpha intercalated cells. This basically is going to cause a change in osmolarity of that filtrate, and it's going to cause more potassium to come out. We also have loop diuretics like Lasix. And something I'm not going to focus too much on is the luminal anions, so don't worry about that. So let me just explain why the diuretics can cause changes in potassium secretion, leading to increased. The most commonly used diuretics, like the loop diuretics, Lasix, and thiazide diuretics, cause increased potassium excretion. And in order to excrete it, we also probably need to secrete it as well when we're talking about the late distal convoluted tubule, again, the variable region. Therefore, an important side effect of diuretic therapy is hypokalemia. The basis for the diuretic-induced increase in potassium excretion is increased potassium secretion by the principal cells. Again, principal cells, if you remember from your electrolyte lecture, they respond to aldosterone. And when those cells reabsorb more sodium and water, they must secrete potassium. Loop diuretics and thiazide diuretics inhibit sodium reabsorption upstream to the site of potassium secretion. Loop diuretics work in the thick ascending limb, and thiazide works in the early distal tubule. So those are all before we get to the late distal convoluted tubule. And as I said, this delivers more sodium to the principal cells in the filtrate. When more sodium is delivered to the principal cells, more sodium enters the cells across the luminal membrane. And more sodium is extruded from the cells on the basal membrane out back into the blood through the sodium-potassium ATPase. And this means we're going to have more potassium pumped into the cells, increasing the intracellular potassium concentration, and this leads to an increased driving force for potassium secretion. So that is another reason why diuretics can lead to more secretion and hence excretion of potassium. Now conversely, potassium-sparing diuretics like amiloride and spironolactone are going to inhibit the actions of aldosterone, either inside the cell or by blocking channels on the apical membrane. Again, I talked about this in your electrolyte lecture. So I just went through some of those reasons, ways to regulate potassium secretion, again, in the variable region of the principal cells. And here are those two cells. Up at the top, we see the alpha intercalated cell, and down at the bottom, we have the principal cell. The principal cell and the alpha intercalated cell on the basolateral membrane, they both have the sodium-potassium ATPase. Remember, this faces the blood, so I'm drawing my blood vessel. The principal cell responds to aldosterone, which is a steroid, which means it can cross the cell membrane. Its receptor is inside. Aldosterone increases the number and activity of sodium-potassium ATPases. This increases the potassium level inside the cell, decreases the sodium level inside the cell, and on the apical side, we have these leak channels. So if I have a higher concentration gradient of potassium, then it's going to want to diffuse out into the filtrate. And sodium will have a greater driving force to come inside the cell. This is why aldosterone leads to more sodium and water retention, but we get more potassium secretion. So the principal cell is all about reducing potassium from your blood. It helps you if you have hyperkalemia. The alpha intercalated cell, however, helps you if you have hypokalemia. And that's because it has this hydrogen potassium ATPase. Remember, the hydrogen ATPase shown up here is mostly for acid-base issues. The hydrogen potassium ATPase is mostly for hypokalemia. You don't want that last 15 to 13% of your filtered potassium ending up in the toilet. You would be in a negative potassium balance. You need it. You need to keep it. So the alpha intercalated cells are all about saving some of that 13 to 15% of the filtered load of potassium when you need it, when you are on a low potassium diet, for example. Okay, well, I'm going to end there. I could keep going, but it starts to get circular. Again, the point of this long lecture for such a short PowerPoint slide number is to, one, again, expand the renal compensation for acid-base balance. Two, show you how acid-base balance can lead to potassium problems. And three, explain to you the difference between internal and external potassium balance.